of our monthly SIG webinar series on SIG University, helping everybody be up to date what they need to know regarding healthcare reform, compliance, and any other issues that have come up since the last call. Today we have Stacy Barrow on the call with us, and we're pleased as always to have him join us. For those that are on the call, please remember that if you have any questions, feel free to email me or text me. I have my phone ready to take all your calls and questions so that as we go through this, if anything resonates with you, you want Stacy to clarify something, that you can do that. And again, SIG is pleased to be a leader in providing compliance and healthcare reform information to many of our clients and friends of the firm and advisors. And so if there's anything that you would like us to put on the agenda for any future webinars, feel free to shoot us an email, give us a call, and we'd be happy to do that. We're going to take the first few minutes of this webinar to really focus on a topic that's important to all of our self-funded clients and any of our fully insured clients that have HRAs, and that is the PCORI fee. And what's also important for all those people on the phone that are fully insured, one of the things that we're seeing in a lot of your renewals is we're seeing you see that line added for the PCORI fees, the transitional reinsurance fees, or the healthcare reform fees and taxes. And on some of the fully insured carriers, we're seeing like 3.4, 3.6% being added. For our self-funded clients, it's pure pass-through that needs to happen. So we're going to take some time to go through that because that's very important, and those fees need to be filed by July 31st. So let's jump in and bring Stacy in just to start going through some of these slides, and we're not going to go through each line by line because many of the folks on the phone can read at their leisure. But Stacy, let's go through the first slide and just talk about the PCORI fee. And again, thanks for being available.
Thanks, Richard. Good morning, everyone. It's Stacy Barrow from Foscauer. So let's see, like Richard said, let's start with the PCORI fee. The first thing to point out is that if you're fully insured, the carrier is responsible for paying the fee. And you'll see this on your renewals, but there's no separate filing for you if you're fully insured. If you have a self-insured major medical plan or even a self-insured health reimbursement arrangement, though, you will have your own filing requirement with respect to the PCORI fee. So this year, some folks that are filing will pay a fee that is $1 per member per year, and others, depending on when the plan year ends, will pay $2 per member per year. If you've already paid the fee once, and you paid the $1 last year, this year is your $2 payment. If you have not paid the fee yet, this will be a $1 payment for you. One note to point out is with regard to HRAs, the health reimbursement arrangements, the member count is calculated a little differently for HRAs. You're only looking at the number of covered employees when you pay the fee for an HRA. You do not look at any spouses or dependents that may be eligible for coverage under that HRA. That's because typically members or family members aren't even really enrolled in an HRA. They're simply eligible to have their expenses reimbursed. So again, HRAs counting only employees. Other self-insured major medical plans will count employees, spouses, dependents, any members.
Stacy, one thing that we talked about on Friday is, I think, in the fourth bullet down, is that people need to pay directly to the IRS. The TPAs cannot pay this fee for them. I know that we had that discussion regarding some potential changes on the transitional reinsurance fee. So could you sort of comment on that as a lot of people say, well, I thought my TPA is taking care of this for me?
Yeah, pardon me. With respect to this fee, the PCORI fee, the TPA cannot file the Form 720 on behalf of the employer. The fee is actually assessed on the employer. It's based on participation in the group health plan, but it is an employer obligation. I'm not aware that carriers are really doing much to assist in this. Maybe you can look to your TPA to help you with the counting, because there are a number of fairly complex counting methods.
and we'll cover that in a little bit. Okay, next slide. So this is pretty clear cut, right? Needs to be submitted by July 31st.
That's right. Yeah. So, and just to be clear, when you're submitting the fee by July 31st, it's for the plan year ending in the prior calendar year. So even if you had a plan that ended, say, January 31st of 2013, you would wait until July 31st of 2014 to pay that fee. And this slide is showing when the first fee was due, July 31st of 2013. Really only calendar year plans paid the fee last year, or plans with a November 1 or December 1 plan year. So if you didn't have a calendar year plan, this is very likely your first year paying the fee.
Okay. So let's just go over who needs to pay the fee. We sort of touched base on that, but this sort of covers that here.
Yeah, there are no major blanket exemptions for self-insured plans as far as the fee goes. It applies to grandfathered plans, church plans, retiree plans, government plans. There are certain exceptions for government programs like Medicare, Medicaid, CHIP, federal programs. We mentioned that you're responsible for paying the fee even if you have a fully insured plan. If you have the HRA is subject to the fee. HSAs generally are not ERISA plans, and so you would not pay a fee in connection with the health savings account.
Okay. And Stacy, one of the things that you and I talked about, and for those on the phone, because as many folks listening, and as we hear, one of the things that really concerns many of our HR people and many of our CFOs is that increase in Department of Labor audits, and they're going to come knocking on the door, and if a form did not get filed or something occurred, there's some onerous fees, and we'll have a blog out on our website next week about that, and that'll be covered at one of our webinars. But you and I talked about that on the PCORI fee. To the best of your knowledge, right now there's no it basically somebody has to pay their back fees and interest, but right now there's not like a $100 a day per employee penalty.
Right. Yeah. So as you kind of alluded to, under the ACA, when you have failures to comply with the insurance mandates and the market reforms, those types of mandates generally generate a $100 per affected employee penalty for failures. This PCORI fee is a little different. Failure to comply with the PCORI fee doesn't generate that $100 per day penalty, but there are interest and other penalties that apply based on failure to file this form. So, of course, we still recommend you get it filed in a timely manner.
Okay. Now, the big thing is how do you account for that? And there's several different methods for accounting. There's the actual account method, the snapshot method, the Form 55 method. We're just going to touch on those now, but and if you have any commentary for those on the phone as to if you were a plan sponsor, is there any particular one you would use or when you use one versus the other? So let's just touch base on the actual account method for now.
Sure. And as you suggest, this is a kind of a high-level overview. These are oddly complicated for what would seem to be something fairly straightforward, like counting participants. Actual count method, you basically just add the number of lives covered on each day of the plan year and divide that by the number of days in the plan year. That's relatively straightforward. Actual count method. The next one is the snapshot method. That one is a little trickier. You basically select a certain date or dates in each quarter, and then you look at the same date in each of the following quarters, and they're basically taking a snapshot of your membership on a quarterly basis. And then you can use an actual count there, or you can use a factor method to determine your count. So it's either looking at the actual count or you're using a factor to determine what your family or non is its employee-only coverage count is, and that's using a factor of 2.35.
Okay. And then the next one is the Form 5500 method.
Yeah, and I think this one probably is the most straightforward and maybe the one that's going to be most likely to be used by employers. You know, most of them do have a 5500 obligation and file those 5500s. And due to the timing of the PCORI fee, you should have all the information necessary to use the 5500 form or method to calculate the fee. And there's a bolded sentence here that's important to note, is that you can only use this method if you've timely filed your Form 5500 without extension.
Okay. Now, let's say we have clients on the phone that haven't filed a 5500, and let's say that are less than 100. You know, we have a bunch of clients that have HRAs, and we have a bunch of clients that have under 100 that are self-funded. Is there a pro or con if you were the CFO of a company as to whether to use the actual count method or the snapshot method?
Actual count method might save you a little bit of time, but if you had a lot of participants, well, I guess you always have under 100, but you could always run both of them and see which method worked out the best, economically.
But we're not talking about a lot of money.
Yeah. I mean, I would probably, for ease of administration, just go with the actual count method. And then one thing I just want to mention on the 5500 method, because I know this is often a little confusing when people do the filing, is that on the front form, the main form, the 5500 itself, when they're talking about putting down participants, for 5500 purposes, participants are employees. And so, if you're putting down the total membership on the front of the 5500 and you use the 5500 to file the PCORI fee, you're going to overcount or double count your employees or your participants. On the Schedule A, the Schedule A is reporting everyone, the members, the employees, spouse, and dependents, but the front page, the 5500, for a welfare plan should only be employees. And when you look at how this method works, you can see that it makes sense that for a plan offering self-only coverage, you take the participants beginning and the end of the year and divide by 2.
Okay, and for those that are on the phone later on today, the recording and the PowerPoint will be on our website, or maybe by tomorrow will be on our website. But the SHRM website has a lot of good content that allows you to sort of drill down on each of these areas. And so we have some slides in the back of these slides along with certain links that I think would be beneficial for those that really want to drill down. Also, for those that are our clients, we're going to be sending out a Proskauer news alert along with the recording and the PowerPoint. UMR, actually I have it right here, has a really excellent sort of pamphlet, very detailed, easy to read, and so we're probably more than likely going to send that out so that the people that really want to get their arms around it even more without getting lost in the sauce, so to speak, and easy to find some information, we're going to provide you those resources from that standpoint. And then we want to thank our folks from Pentra who have been working with us with some of this information. Our band partner in Philadelphia who provided some of this, and they're helping our clients. I think the next slide is just something that regarding the first-year fee that was in effect that we don't need to spend a lot of time on. But Stacy, could you comment about COBRA and retired beneficiaries for those folks that are on the phone?
Yeah, they're included in the membership count.
Okay.
The COBRA folks and any participating retirees are included as employees for these purposes.
So let's say I gave somebody severance and they haven't started their COBRA yet.
Yeah, they would be included in that count.
Okay. Let's see. We have a question. Our first question from one of our clients that says, "How can the fees be charged to the plan? Snapshot method, are we reporting total number of employees or lives participants?" So on the first one, how can the fees be charged to the plan? this person who answered this is fully insured, and so they're going to get billed by the carrier for the PCORI fees and the transitional reinsurance fees, and then they can decide, you know, and we have a lot of clients that are self-funded, that basically saying is, hey, I do an 80-20 split or 75-20 split on the premium, but I'm passing the PCORI fees on to the participants, and I'm going to build that into the employee deductions. So could you comment on what you're seeing and what your thoughts are on that?
Yeah, like you said, so when the fee is assessed on the plan, when it's fully insured, it just comes through in the rate. And you know, when the plan is insured, the fee is assessed on the carrier can pass that through. The employer has a standard contribution rate. Maybe they're paying 75%, maybe they're paying 80%, and then, you know, the fee is just, you know, assessed through the rate. When you're self-insured, the fee is assessed not on the plan, but the plan sponsor. And so employers really shouldn't be building this into the premium equivalent rate. So, you know, what we suggest is that if you want to pass the PCORI fee on to participants, you would do so by lowering your employer contribution rate, but you really shouldn't be building in that PCORI fee into the premium equivalent.
Okay. However, we do have many of our clients that, especially as you have newsletters and open enrollment packets go out, you know, a CEO letter, we have many people that are communicating that, you know, we got hit with this X increase, and then on top of that we get hit with $400,000 in, you know, healthcare reform taxes and fees, and for that reason, that's why the deductions are going up. So there is some education from that standpoint. Her next question was on the snapshot method, are we reporting total number of employees or lives participants, or sometimes we say belly buttons?
Yeah, under any method that you use, you're always looking at members unless you have an HRA. If it's a major medical plan, you're always looking at the total number of covered lives. Under the snapshot method, you can either look at the actual number of those covered lives, or you can just take your employee-only count and then your count of employees with other than employee-only coverage and multiply it by 2.35, so you use that factor. But in either case, you're either actually counting all the members or you're approximating all the members.
Okay, great. Okay, I think that, let me see if there's any other questions we have, not right now. So with that, we're going to go into the couple comments on the transitional reinsurance fee.
Sure, okay. So this one is first effective in 2014, and this one, unlike the PCORI fee, this applies on a calendar year basis, regardless of plan year. And so this one is, it's slated to be, or it's expected to be $63 for 2014, and then the estimates for the next 2 years, this is only a 3-year fee, are expected to be somewhere in the range of $42 per member per year for 2015, and then $26 per member per year for 2016. And these are all essentially estimates at this time. The fee is due by November 15th of each year, and you basically are going to submit a count to HHS. Within a month, they'll notify you of the amount, and then you have 30 days to pay the fee. And there's a couple of ways that it can be paid. There's an ability to pay a portion of the fee by that January 14th date, and then make another payment of another part of the fee later in the year. But I think for ease of just getting this out of the way, I think most employers are going to end up just paying the bill completely when they get it assessed from HHS.
And again, this is if you're fully insured, this is a bigger cost that's built into your rates, and if you're self-insured, you know, then this is something that you're, you know, paying from that standpoint. And to clarify that, because we talked about the PCORI fee, if you have a HRA, this really doesn't apply, because if you're fully insured, it's built into the premium, and if you're self-funded, then you're paying that directly.
Yeah, so and thanks for pointing that out. So just to be clear, this transitional reinsurance fee, if you're fully insured, the carrier pays it. If you're self-insured, you're responsible for it, but only with respect to a self-insured plan that provides minimum value that's at least equal to a bronze plan. So any HRA is almost certainly not going to provide minimum value, and so your HRA type plans do not pay the transitional reinsurance fee. Likewise, what they call a skinny plan or an MEC plan, a minimum essential coverage plan, if that bare bones plan does not provide minimum value, it's not subject to the transitional reinsurance fee.
Okay. And then I think just to take a step back for those that are on the phone or those that are listening, this is, again, the fee is basically that the government has said to carriers, in order to participate on the exchange, and we know you're going to be sort of selected against with bad risk, we're going to basically charge every plan this transitional reinsurance fee. And I saw an editorial in the Wall Street Journal that said they were collecting like $8 billion, and then they're sort of redistributing that out to the carriers based on their market share on the exchange to help sort of defray the costs they're incurring of ensuring that bad risk during the first few years of the exchange getting set up. Is that basically the Reader's Digest version, or anything you want to add to that?
Yes, no, that pretty much covers it. I mean, it is essentially taking money from the plans that traditionally perform pretty well, which are employer-sponsored plans, and holding it in reserve for the exchanges in case they have severe adverse selection, which I think we're all probably expecting to happen. I know, we have had our own version of healthcare reform in Massachusetts for years, and when we first opened up our version of the exchanges, they attracted the individuals who were already in need of care, were particularly high income, and so we did see a little bit of adverse selection, and I think we're already starting to see that based on the reports that we're getting from the government on the exchanges. We know that there were not as many younger people enrolling in the exchanges as we really wanted, so I think they might need some of that reinsurance money.
Okay, we have another question that just came in on the transitional reinsurance fee that says, when we calculate the number of participants, will we be looking at the 2013 plan year or looking back from November 2014 to November 2013? And this is somebody that's on a 1/1 renewal year. So they're really looking at the calendar year, right, Stacy?
Yeah, and everyone's looking at the calendar year regardless of your plan year. This is a calendar year fee regardless of plan year.
Okay. Okay, and then the next thing is just a picture from the Form 720. It was interesting. I downloaded the Form 720 and the instructions, and it's, there's like 100 different things the Form 720 is used for, but on Part 2, there's a spot that, basically where you fill that out. It's pretty self-explanatory and easy to use from that standpoint. Okay, so I think we've covered what we need to on PCORI. Go ahead.
Let me just jump in with one more just clarifying thing on the reinsurance fee. You can use the 5,500 method to pay the fee, and so then you'd be using the 5,500 that ends in the year being reported. But everyone's going to pay the fee on a calendar year basis.
Okay, great. Okay, thank you. I think we've covered what we need to on PCORI transitional reinsurance fee, but one thing that sort of ties to that is our next question, and I think that's something that that people need to know about. And again, for those that are on the phone, this applies, the HPID applies to both self-funded plans and HRAs, because under healthcare reform, basically an HRA is like a self-funded plan. Correct, Stacy, on that?
That's right, the HPID.
Yeah, so let's talk about what is the HPID, what is an HPID, and why, what do employers need to do and be worried about?
So, and again, this is just for self-insured plans. Fully insured plans, the carrier will take care of this.
But how about if I have an HRA with a fully insured plan?
Yeah, so HRA being a self-insured plan will have an HPID requirement. Now, HRAs are almost universally going to be what they call small plans, meaning that They don't pay more than $5 million a year in paid claims. And so HRAs will have an additional year until November 5th of 2015 to get their HPID. So if all you have is an HRA in terms of self-insured plans, then you'll have an extra year, and maybe we'll see some more guidance between now and then as to how really to treat an HRA here.
That's a big relief to all of our fully insured plans that already dealing with lots of stuff to even think about having to do HPID because of the complexity of it. So that's good news.
Yeah, that's right. I mean, the system for obtaining an HPID, if you're self-insured, is a little tricky because it really seems to be geared more towards providers. And you'll see this if you go on and you click into some of the drop-down boxes. It'll ask you for things that only a carrier would have, and it's just it's oddly confusing for just basically getting an ID number that a self-insured plan is never going to use. The number will be used when the plan makes a standard transaction under HIPAA, but if you use a TPA, it's going to be the TPA's number that is going to be used as the identifier. So really only self-insured plans that are self-administered are actually going to use this HPID number, and I think very few of our clients that are self-insured are also self-administered unless they're multi-employer plans. So
okay.
The average employer-sponsored plan is administered by a TPA if it's self-insured.
And so let's go over, like, you have to go to the IRS website, and you have to go through that, and you have to do drop-down boxes, and like you said, it's confusing. And so is this one where the employer really has to be the one to go on and do that?
Yeah, and it's actually a CMS website.
I'm sorry, right, CMS.
So no reason to confuse folks more on this one. Yeah, the IRS one is for the PCORI fee. HHS is the reinsurance fee. CMS, which is a part of HHS, is where you're going to be doing the HPID fee. And actually, they've just kind of changed the site for the reinsurance fee. They were going to use a similar system for the HPID, but now you're using pay.gov to pay the reinsurance fee. So I know this is all crystal clear, but at any rate, you'll be using this CMS website. I think they call it HIPPOS. It's HPOES, or HIOS, HIOS. There's a couple of different systems out there, but it is an employer responsibility. The TPA or broker really can't go out there and obtain one of these numbers on behalf of an employer. Someone from the employer that has the ability to bind the company basically has to go on and make this application. One point, and just to go back to the reinsurance fee again for a second, I mentioned that there's going to be a different website now to pay the fee. It's going to be pay.gov, and it looks like the TPAs will have a little more of an ability to help employers with the reinsurance fee. And while they won't be able to necessarily go on and sign off and click the final submit button, the TPA should be able to provide the information that's necessary for the employer to go out on pay.gov and just write in the member counts and all the other pertinent information. So we're hoping to see some help from the TPAs when it's time for employers to pay this reinsurance fee.
Okay, great. Okay, so let's move on to a couple of questions. We're going to come back to this next question and then skip ahead to see what a client's thinking about doing. So, as we know, healthcare reform, medical trends, 8%, 9% for some fully insured carriers. If you're fully insured, you're seeing about a 3.5%, 4% hit with healthcare taxes and fees, self-funded, maybe 1.5%. So people are really focused on wellness and employee engagement and looking for people to get improved outcomes. So here's a case where somebody wants to have a wellness program where they basically want to give wellness credits for different criteria in terms of biometrics and looking at, people have to, have certain, waist circumference, blood pressure, cholesterol, triglycerides, blood glucose, and again, this will be in the slides for you guys to look at your leisure to really focus on that. Because, you know, the state of Alabama and the state of North Carolina, there's things that they're doing in terms of government employees measuring waist circumference, and if you're not engaged with a nurse or a coach, you're going to pay more. So when you have something like this, the question is the below incentive allowed? And, you know, we're not going to take a lot of time on that, but just sort of talk about what you're seeing with your clients and people looking to do these plans and what you would want them to know you can and can't do.
Sure. So, you know, all of the metrics on that prior slide, you know, the waist circumference and the blood pressure, you know, requiring employees to meet these metrics is a, you know, classic outcome-based wellness program. And so, you know, if you're, we'll use Richard as an example, he can probably meet all these biometrics. Me, I would have trouble probably meeting the blood pressure one. And so, you know, anyone that can't meet that initial standard must be provided a reasonable alternative so that they can earn the full reward. So, you know, if I couldn't meet that blood pressure standard, then there would have to be some kind of alternative. Maybe it would be meeting with a health coach. Maybe it would be meeting a different standard. Maybe it would only have to be under 150. There are different rules that apply depending on the reasonable alternative, but the bottom line is that, you know, the rewards under a wellness program should be available to every participant, and even those that cannot meet the standard. So, you know, anyone that can't meet this and any of these initial standards that are outcome-based, you know, where you're actually requiring someone to satisfy a standard related to a health factor, then you need to provide them a reasonable alternative. Now, just as a different type of example, say you had an activity-only type of a health contingent wellness program. Say you had a walking program where everyone needs to walk around the block a few times during lunch. There's no particular outcome. You know, you're not requiring them to lose a certain number of pounds or have a certain waist circumference, but someone that, say, just had ankle surgery wouldn't be able to participate in the walking program. And for these types of programs, you need to offer a reasonable alternative, but only if it's unreasonably difficult or medically inadvisable for the participant to satisfy the standard. So, you know, if you have a walking program and I say, oh, I can't participate in that, you would be able to essentially say, you know, well, why? Is it unreasonably difficult? Is it medically inadvisable? And I could say, well, yes, you know, for me it is because I'm recovering from ankle surgery. You can see that I'm hobbling around on crutches. And so in that case, they essentially have to, you know, provide you the alternative standard. If it's not obvious as to your condition, then you can require employees to verify that they have a condition. Like, say I had, you know, like plantar fasciitis, which, you know, makes it painful sometimes to walk. Then I could, you know, the employer could say, well, we need a doctor's note to show that you have this and that it really prevents you from engaging in a walking program.
Okay.
If the doctor agreed, then he would write the note, and if he didn't agree, he'd say, no, you got to get off your butt and get walking. It would actually be good for your condition.
Okay. So, so I think that's great feedback, and I think for all those on the phone, I think pretty much, you know, I just saw a stat the other day. It says for large employers, pretty much everybody has some type of wellness program, and what we're seeing is more employers looking to get more engaged in some outcome-based program where somebody is either identified to need to be able to engage with a nurse, coach. And again, when you think about it, 5% of your population are going to drive 50% of that claim cost. So, okay, let's move on to the next question. I just skipped over a little bit of an answer for those folks since that was a long reply from Stacy about the reasonable standard. So the next thing is we have many clients that are self-funded, that, you know, they know somebody is a large claimant, they know somebody has a certain income level and could qualify for Medicaid. Many of the states have expanded Medicaid. So let's just talk about, you know, what can an employer do or not do in terms of educating employees about, you know, Medicaid, either during the year as a new hire, and then that's not here, but I think the other question is incentivizing people to, not incentivizing, let's say, if people come off of the health plan and go into Medicaid, right, and they get free coverage and some cases better coverage at no cost, how that all works. So I'll turn it over to you.
Sure. So, in general, educating employees is fine. You want to educate employees about the availability of other employer coverage. If their spouse might be able to enroll in their own employer's plan, you want to educate them on Medicare or Medicaid or CHIP. Purely educating them is fine. The second part of the question, frankly, I wasn't quite following what they were suggesting about, posting who qualifies for Medicaid.
I think it's more income, like if your income's below $14,000, right? Like we have a sheet that we've given some clients that show that if your income's below $14,000, if you have one dependent below $16,000, 3 dependents below $21,000, you could qualify for Medicaid. And so I think the question is from an employer is promoting that or being more, is there any problem where the government's going to say you're incentivizing people to come off your plan by promoting that, or that's perfectly legal?
No, for you to encourage or incent someone, you have to provide something more than information, right? If you're paying them, to enroll in Medicare, those kinds of things are directly violative of the Medicare secondary payer rules. Oftentimes when you encourage folks to enroll in Medicaid, if they're eligible, what you might find is Medicaid will turn right around and enroll them back on your group health plan and just pay for a portion of their premium. Medicaid has the ability to do that essentially. And you also want to be careful if you're posting things about Medicaid eligibility. Certain states have expanded Medicaid, and then it's very clear in the expansion states it basically covers anyone whose income is under 133% of the federal poverty level. But in states that don't expand Medicaid, there are often different types of criteria, and so like a single male adult might not qualify where a female might qualify, or a single mother might qualify. So just to be careful of how those eligibility rules work.
Okay, great. Okay, so we have a question. We know the answer, but for those on the phone, an example of a question that comes up, and that's if an employee was recently married and wants to switch from a high deductible plan to the basic plan, can she contribute to the medical FSA since she'll be losing eligibility under the HSA? And also, is marriage considered an event where an employee can drop the HSA to elect the FSA?
Sure. So this is someone who's been married or just recently got married, and they want to change from a high deductible plan to a non-high deductible plan. And so when she enrolls her husband into the non-high deductible plan, this would also permit her to increase her FSA election. She would probably go from 0 to having some sort of election, maybe $1,000, $500, whatever it is, as long as the terms of the FSA plan permit that change. And the second part of this question is marriage considered an event where the employee can drop the HSA to elect the FSA? And so marriage is an event where you can make a new FSA election if you're enrolling a spouse onto a plan. Dropping the HSA is kind of a misnomer, because the HSA is your account as an individual. You own that. It's an individual trust account. You're really not dropping the HSA. You're dropping the high deductible plan. And if to the extent you have money in your HSA, you can maintain that HSA account and use it to pay down other unreimbursed medical expenses. You can use it in conjunction with the FSA. You just won't be able to make new HSA contributions if you no longer maintain the HDHP coverage.
Okay. Okay, great. Okay, so our next question is, a couple gets married, the husband's covered under an HSA compatible plan and has established an HSA. The wife is covered under a point of service plan, participates in an employer-sponsored FSA. FSA runs on a calendar year. They like to be covered under the same medical plan. What are the ramifications of switching to one of the other plans, and how are the HSA and FSA affected? Again, sort of taking a little slight twist off the previous question.
Yeah, and I think this is probably more likely to be the case, or I at least hear about this situation a little more frequently than the prior one. And so here you have a husband who's HSA eligible, he's covered under a high deductible plan, and he gets married, and his wife has her own POS plan through her employer, and she also participates in the FSA, and the FSA here runs on a calendar year basis. So what can happen is the wife can drop her POS coverage and enroll in the employee's or the husband's high deductible health plan. However, when they get married, the wife's FSA coverage will disrupt her and her husband's HSA eligibility until the end of the FSA plan year. And unfortunately, this event does not permit the wife to drop her FSA coverage unless she is enrolling in the FSA sponsored by the employee's employer. And so rather than say it that way, I'm just going to say, they cannot drop the FSA election in order to become HSA eligible. I think that's a little clearer way of putting it. There are some nuances to it, but ultimately, this couple's going to have to wait until the end of the FSA plan year to make further HSA contributions once they get married.
Okay, great. Okay, so our next question, we have an account manager that has a group, and the question is we have a couple owners that do not work full-time or take payroll, but they're coming to the benefits today. As you can see the last paragraph, they're looking to know if it's okay and or if we can make them a class called owners or board of directors, make them eligible for benefits regardless of the number of hours worked or payroll, or would this be discrimination? And I guess, we're seeing a lot more of these type of questions, even though we don't have the non-discrimination rules out for healthcare reform. And I know, so this is a topic that has come up. That's going to continue to come up.
Yeah, and you can basically cover owners under a fully insured plan. It's not a problem. You can cover owners and non-employee directors, members of the board, as long as the carrier is on board with it. And you should talk to your own counsel about the best way to structure that in terms of communicating it and amending the plan. But from a coverage standpoint, you can cover owners under a fully insured plan.
Okay. Let's go to the next question. For large employers over 100 that will be subject to the employer mandate 2015, can they use any consecutive 6-month period of time in 2014 to track variable hour employees?
Not exactly. Let's go to the next question, and I'll come back to this one. So I think I should explain.
For employers who must calculate whether they're large or small, can they use any consecutive 6-month period of time in 2014 to average out the number of full-time and FTDs to determine if they are large or small?
Yeah, so here there is a transition rule that says that when you're trying to determine if you're a large employer, rather than looking back at the entire 2014 calendar year, you can pick any period of at least 6 consecutive months in 2014 to do your average. So say you had layoffs in the second half of 2014, maybe you just want to count from July through December to reflect, to capture the fact that you've had some layoffs. That's a transitional rule. It's only able to be used for 2014. So that's how that one works. And so let's go back to the other one because there's a similar rule for tracking variable hour employees, but it operates a little bit differently. So for some employers, and it's really mostly employers that have a calendar year plan. When an employer has a calendar year plan and they're subject to the employer mandate in 2015, they're basically going to be subject on 1/1 of 2015. And if they want to use a 12-month stability period, which is what we generally recommend, then they also have to use a 12-month measurement period. If they want to have a month or two of administrative period, it'll mean that the measurement period will start as far back as November 1 of 2013, possibly. The measurement period would run 11/1 of 2013 through 10/31 of 2014. You'd have November and December of 2014 as your admin period, and then start your stability period 1/1. Now, some employers may not have the data necessary to go back all the way to November of 2013. And so this rule here says you can use a short measurement period even though you want to have a 12-month stability period in 2015, as long as you comply with the 3 conditions. It has to be at least 6 months long. It must start no later than July 1st of 2014, and it must end no earlier than 90 days before the start of the stability period. So I know it's a little tricky, but I'll give you an example that works.
And for those, and what we want to do is maybe not get,
okay,
for those on the phone, what we talked about is we're going to have a session just for people that have variable hour employees, so we just wanted to touch on this. Also, in last month's PowerPoint, there's a whole section on variable hour employees. The other thing I want to remind everybody, you'll see it at the end of the webinar, is that on September 10th, Peter Marathis, who works very closely with Stacy, is going to be in Baltimore for our seminar, annual compliance seminar, and then we're also going to have Jamie Hawkins from one of our partners that really is going to talk about how do you administer all the requirements under healthcare reform in terms of your payroll, tracking employees. So that'll be a conversation that'll be pretty intensive from that standpoint. So why don't we, for time, sort of come back out of that rabbit hole. I appreciate the conversation on that. I want to save enough time to talk about the recent guidance, which was on June 23rd regarding the 90-day waiting period, and I guess more of a Reader's Digest version or a big picture version on people that are on the phone. What do they need to know, or what do they need to worry about as it relates to the recent guidance?
Sure. So, we're releasing an alert on this today. So, we'll have something in writing on this very shortly. But the bottom line is that on Friday, the IRS and the other agencies released final regulations on the use of orientation periods that may apply before an employer starts its waiting period. So those of you that are already familiar with the orientation period rules, the final rules were adopted in identical form to the proposed regulations. So there are no changes. So if you're already aware of how they operate, they continue to operate the same way. But basically, the rules allow an employer to have what they call a reasonable and bona fide employment-based orientation period that starts before the waiting period starts. The maximum length of an orientation period is 1 calendar month minus a day. So you can have that orientation period, and then you can start your 90-day waiting period. And I'll stop, but I just want to give one word of caution, is that if you exploit the full 90-day waiting period and the full orientation period, and you apply this to full-time employees, then you may be exposed to penalties under the employer mandate, because using that both of those periods would, in certain situations, result in coverage not being offered by the first day of the 4th full calendar month of employment, which is what's required under the employer mandate.
So your advice would be?
Is to talk to your benefit consultant at Silverstein if you want to introduce an orientation period for full-time employees. I think it makes most sense to do it for non-benefits eligible employees, or at least non-full-time employees who you want to be who you want to offer coverage to. But other than that, I would just say stick with your standard waiting period, first of the month following 60 days, and I would tend to leave it at that. But if you want to explore it further, I would talk to your consultant.
Okay. And then the other question that came up, and again, we're not entering into politics here, but just we had a conversation on Friday, and then I had a conversation with somebody yesterday that talked about that. But there is some discussion, not that it's percolating, or some thoughts that there could be in for those where the shop was expanded to those groups that were 50 to 99, that could be bumped, or there's some consideration or thought that there may be percolating that could get bumped out to 2017, or could you expand on your thoughts when you hear that.
Yeah, if it's what I'm thinking of, I mean, I had heard a rumor as well that they were toying with the idea of delaying the expansion of small group to 100 or fewer employees until 2017. And so if they don't, what happens is starting in 2016, the small group market is expanded to include an employer with 100 or fewer employees. And I think due to some of the hiccups that they've had with the SHOP program, which is the exchanges for small employers, they may delay expanding the definition of small group an additional year. But I haven't seen any written indication of that. I've just kind of heard that rumor.
Yeah, I was in D.C. yesterday, and somebody else said that. So it's percolating, but so we'll see where that goes.
Yeah, it probably wouldn't be a bad idea.
Right. Well, I mean, we're just seeing some of the issues that we're having, especially here in Maryland with their exchange, and their struggles with just the individual policies, let alone the group. And to think through, you're going to get a group of people with 50 to 100 employees. Just going to make it more challenging. I'm just going to scan through the next few slides just so people can see. I thought the SHRM website had some really good information that on the PCORI fee. So we just took some print screens for you so you could see some of the information there. We have the helpful link below. Also on their site there's some other hyperlinks that you can go to. We've already covered a lot of this information already. Just want to remind everybody, if I don't think there's any more questions that have come up, if there are, feel free to text or email. But we have on July 16th, there's going to be a webinar in partnership with Benefit Advisor Network on exchanges, private exchanges, and defined contribution plans. What we're seeing is a prediction by 2018 that there'll be 40 million people, getting coverage to the exchanges. I've been to several conferences where the feeling is that there's not going to be the capacity to do that. It's a little dot-com-y where you have payroll companies and technology companies all getting into the game. So as we're hearing, there's a lot of discussion but not a lot of action in the under 5,000 market, although there is a lot of action in the over 10,000 market. So many of our folks on the phone are not having 10,000 employees or more, so sort of stay tuned. But if you want to learn about that, if you want to understand that, that would be a great webinar to listen in on. And again, all of our webinars are recorded, and they'll be posted on our website. And then again, July 23rd, we'll have another healthcare reform compliance with SIG University. And so please feel free to email or to contact your SIG team member regarding anything that you want covered. It's great to continue to get information from you that you'd like Stacy to address during these webinars from that standpoint. And then we just want to remind everybody to save the date. I think we're going to have a packed house. Historically, we get about close to 180 people to our seminars on compliance with Peter, and now with Jamie coming in and really having you understand all the things that you need to track and making sure that your payroll system and your HRIS system and your internal systems are what they need to be. That's going to be a great meeting from that standpoint. Stacy, is there anything else that you have that, the final few minutes that we have, that any particular things that you've been asked about, any cases that you think the folks on the phone would want to hear about? Where we've covered everything?
I think we have today. Nothing immediately jumps to mind.
Okay. I found a piece that I just wanted to reference that people could think about as they think about our seminar on September 10th, and being sure to save the date. But here's an article that we'll be sending out that says, what PPACA, what needs to be tracked? Flexible spending account annual limit, detailed dependent information that is needed for quoting, employee acknowledgments of SBCs, employee acknowledgment of notice of exchange, Form W-2 reporting, PCORI fees, which we covered today, waiting periods limited to 90 days, wellness incentives, full-time, part-time status, and hours worked, measuring stability and look-back periods. We'll have some further discussion about Form 6055 and 6056 reporting, which is extended 2015, and then automatic enrollment rule, which is pending some guidance. So, I think the one thing that I think you would agree is with the increase in Department of Labor audits, it's more important than ever that people really understand how their internal systems are set up and controls are set up, so that if there was a Department of Labor audit, they would know that the CFO is not going to be disappointed.
Yes, absolutely.
Okay. Okay. Well, I think we're going to finish a couple minutes early. I just want to thank you for being available as always. It's great to have you on the phone. Hold up. I think we have one other question. Sorry. One other question. We renewed in July 2013. Does that mean we don't need to file by July 31st, 2014? I guess that's for the PCORI fee. Somebody saying they renewed July 2013. Does that mean we don't have to file by July 31st, 2014?
They would file by July 31st of 2014 for the plan year that ended in 2013. So the plan year ending 6/30 of 2013 that started 7/1 of 2012, your first filing is due this July, and you pay $1 per member per year.
So, Bobby Joe, that's your answer, and that's why we're glad that you're attending and that we have Stacy on the phone. So anyway, hope everybody has a great rest of your day. Hope everybody enjoys the rest of your summer, especially as those are heading off on vacation. Again, special thanks to Stacy, and thanks for all those that attended and all those that are listening to this as a recording. Feel free to contact your SIG representative if you need any help. And also, for all those that are on the phone and that are listening to this, you're going to be seeing a lot of more content on our website. We're working with a partner firm to get recordings, to get pretty much white papers, anything that you need. We want to become the SIG University place of choice for anything compliance and healthcare related. And so keep an eye out on that. Again, next week we're going to have a blog out that I think you'll enjoy about Are You Ready for Department of Labor Audit, since we're seeing a huge increase in that. Last year there were 274,000 complaints that triggered a Department of Labor audit by employees. So, stay tuned. Stacy, thanks again and have a great day.
Thanks, Richard. Take care, everyone. Talk to you soon.